This meeting is being recorded.
Is giving an advantage, and this is difficult to capture in trial. What we have seen in the latest trial is that also the stent thrombosis was improved. The stent thrombosis rate was improved with imaging. Maybe we can see better the under-expansion that we cannot see with angio with imaging, and there we can have an impact on the stent thrombosis. So there are many factors that have to be taken into consideration, and I like your last comment saying we need maybe to tailor a little bit our strategy. So on when to use it or when not to use it, imaging and physiology. Do you have any specific advice to give when to use it and when not to use it?
Well, that would be the standard advice. I mean, you need imaging when you have a complex lesion, when you have a left main, if you have very much calcium, when you're unsure if you have dilated enough and so on, and also to check the results if you have some dissection at the ends and so on, if you have some suspicion of that. So that's the standard answers for that. I think the main message is that the Bioadaptor is not different from other stents with regards to using imaging or using physiology or just using angiography.
Go ahead.
Just a quick question. What are your thoughts on acute coronary syndrome versus chronic coronary syndrome and the performance there? Was there any difference?
No, don't have any data right here, but we haven't seen any interaction for those two ones.
You know, I like to point out that this is a post-hoc analysis. So with all the limits, I think can be hypothesis generating, but is partially contradictory to the Syntax 2 study, where again is another non-randomized comparison, where the difference between Syntax 2 and Syntax 1 were remarkable due to the introduction of FFR and IVUS. So I think the field to me is still open.
Mm-hmm. Yes, I agree. I mean, this is a small sub-study. It doesn't answer the question about imaging versus non-imaging or physiology and non-imaging. I think the important thing is that I so many times get this question. Do I have to do imaging to use the Bioadaptor? Do I have to do physiology? And this data, we have some data now that is not necessary. You should do like you do in your regular practice and use it when you want to.
The Infinity trial was actually the most compelling trial showing the evidence of the benefits and the superiority of the Bioadaptor versus metal regular DES. But it was kind of a more common study. Are there still subsets that we need more evidence on? Subsets of patients or groups or lesions?
Yes, I think so. I mean, we had a lot of ACS, we had STEMIs, we had relatively complex lesions, but we didn't have, for example, CTOs like Colombo has studied, and really complex lesion, we didn't have any left mains. Should we use the Bioadaptor there? We don't have that answer. So more complex lesions need to be studied.
In our group of complex lesions, the results were quite amazing. We had some cases of impressive positive remodeling of CTOs, long lesions. So I think a prospective randomized study in complex lesion is
I think we'll move to our next speaker. Thank you very much, David. We're going to hear about the 5-year outcomes of the Future 2 trial. That is the thin strut bioresorbable scaffold, LASONG.
Thank you. Good afternoon, everyone. I'm Dr. Song from Fuai Hospital. I'm pleased to present 5-year outcomes of thinner strut FireSoft scaffold in Future 2 trial on behalf of the Future 2 investigators. This is my disclosure. As a background, first-generation BRS scaffold was associated with excess adverse events, particularly device thrombus, limiting their clinical use. In the randomized Filter 2 trial, the new generation single structure FALSOP BRS demonstrates comparable clinical outcome at 1 year and 2 years, 3 years, compared with contemporary EES. And the key question is whether this safety profile could sustain over 5 years. And FALSOP BRS is a single structure PLA-based sirolimus eloting scaffold designed to reduce luminal protrusion and improve local hemodynamic profiles. And its thickness is much thinner than the previous generation BRS, 100 to 125 micron, depending on the different platforms. And the Filter 2 study is a prospective multi-center randomized trial. All the patients will randomize with 1:1 ratio to FALSOP BRS and cobalt chromium EES. And the primary endpoint is 1 year in segmented lumen loss. And all the patients will be followed up over 5 years. And today we will report the final result of the 5-year follow-ups. A total of 528 patients from 28 centers were assessed for eligibility, and 433 patients were randomized. After 5 years, and 417 patients for complete 5-year follow-up, as the follow-up rate was as high as 96.3%. And the baseline characteristic was balanced between the two arms, including age, sex, diabetes, previous milk infection, ejection fraction, and clinical presentation, as well as the vessel location and the pre-procedure QCA parameters was balanced between the two arms. And the overall success rate was high, and 99% for the FALSOP and 100% for the EES. And the post-dilatation was more frequent in the FALSOP, which is usually and expected for all the BRS implantation. And the angiographic and procedure result was acceptable under the both arms. And for the primary endpoint of in-segment lumen loss show non-inferiority for the BRS and the EES. And the cumulative frequency distribution curve was also similar between the two arms, which show a similar performance of this new device compared with the EES. And for the 5-year follow-up, the TLF was similar between the two arms, about 5.5% for the EES and 5.2% for the BRS, as well as the component. And more importantly, there was no device thrombosis over the 5 years at both arms. And we were talking about the component of the target lesion failure, including the cardiac death, the target vessel myocardial infection, and the ischemia-driven respiration was also low and similar between the two arms. And we also performed the landmark analysis, shows that the target vessel, target lesion failures was also without any late divergence after 36 months, and the curve remains stable between the two arms, which is very important for this bioresorbable scaffold. And because of the 3 years, the process of resorption have started. And it's similar also for the patient-oriented component endpoint as POCE through 5 years. The curve remains stable because this is also important because this demonstrates that the overall patient-level safety was also sustained over the 5 years. And a summary, and 5 years Filter 2 results support the sustained safety and efficacy of the single struct sirolimus eluting bioresorbable scaffold, with a long-term clinical outcome comparable to contemporary ES in non-complex coronary lesions. Importantly, no definite operable device thrombus was observed over 3-5 years. Of course, our result was not to show that this device could be used broadly without patient selection, but however, our result highlights the importance of the patient selection and the support for the evaluation for the FALSOP in a broader and more complex patient and lesion subset. Thank you.
To Dr. Colombo for commentary on the trial.
Yeah, but first of all, I'm very happy about these results. At least we have a breadth of rejuvenating these technologies that suffered tremendous troubles throughout the years. I have, so these results are encouraging, simple lesions, low number of events in both groups, most probably, as I said, related to the lesion selection. I have 3 questions. How long does it take to fully degrade? The first question. What was the dual antiplatelet therapy regime for the bioresorbable? And the third question is, how frequent was the use of imaging in this study?
Thank you. Thank you for your question. First, this device, the fully complete resorption in the animal study is 3 years. But for using the film study of in the human being, we observed after 4 years. Between the 4 years and the 5 years, the device will be fully resorption. And the second question is DAPT. Both based on the protocol and all the patient will be treated with DAPT at least 12 months. The extended longer DAPT is not mandatory for all the device, including the BRS. But as we know, the doctor and maybe because this is not a blinded randomized trial, and so the doctor and the patient now they were randomized to BRS, and the patient maybe the doctor wanted patient extend their the DAPT process, and based on I'm not have the exact number, but now more than 20% of patients follow the extended DAPT therapy. And the third question is imaging, and despite we have a set OCT subset sub-study of this randomized trial, about 40 patients in each arms, and besides these 80 patients, and the imaging guidance is relatively low for this study, now more than 10%.
So I think this is important because it shows that this device, at least in this type of lesion, does not need a routine imaging, which is good and bad, but at least for the real life, we know that imaging is not routinely used. And is the company planning to do a complex lesion study, or there is a study undergoing in this more difficult subset?
Yeah, good recommendation. And those 225 patients in Tutor 2 and another 1,000 patients in the real world, and we have a 1,200 patient data, and it also improved good result.
Okay.
I just want to ask you, just to you kind of mentioned it in your presentation, but following up what Dr. Colombo was saying about when it's resorbed completely. So when does it actually begin the resorption? And is that when you noted some events starting?
Yeah, it's a start. I also separate with animal study and human study. In animal study, it started at 2 years. But for the human, we observed it started at 3 years. 3 years to until the 5 years. After 5 years, fully resorption.
I also have a short question. So the previous version of the bioresorbable device basically failed because we used them very broadly. We end up having high rate of scaffold thrombosis, and then we put the technology aside. Here we have some promising results now. So I'm just thinking if we need to think a little bit carefully before using this technology in highly calcified lesion, very complex lesion, or maybe this is an interesting concept because you just don't put anything permanent in the coronary. And maybe we can also think about a niche of lesion that are best used with this kind of device, so maybe more simple lesion, soft plaques, this kind of subset that might have a higher advantage of this device, even in young patients. So I'm just thinking if this could be a niche of patient where this kind of technology can be useful, and if we need to think twice before putting this kind of technology in a highly calcified lesion that are difficult to expand in some cases.
Yeah, thank you. I have no data because this randomized trial we exclude those very complex cases, particularly for the very severe calcified lesion, because for the platform of PLLA, we have to maintain some thickness of this scaffold to provide the enough radial support, and for the calcified lesion, I think it's for the current version of the stent is not good enough, and I think. So we want to highlight the importance of the patient selection and the lesion selection, and also the imaging guidance.
You know, perhaps part of it is lesion prep. So if you're doing more lesion preparation, even though these were not necessarily complex, and these are thinner strut bioresorbable. So I think, to me, these seem to be the two biggest differences between it, and unfortunately, they failed absorb, 5 or so years ago.
I agree, totally agree.
Good. Thank you very much, Dr. Song.
Thank you.
We continue with the next presenter, Alexander Abezit, who will talk about site-specific antithrombotic therapy, the Design BDS Plus trial, the 36 months outcomes.
Good afternoon. Thank you so much, Peter. It's a pleasure to speak in front of this very distinguished panel full of great friends. And my task in these next few minutes is to describe the results, the long-term results at 3 years for this very unique site-specific antithrombotic DES. These are my disclosures. I always like to start giving credit to the people that put a lot of work for the success of this study in multiple geographies around the world, but also important CROs that help us to collect data to be able to present and publish. Just a single slide as a rationale. I think that you're very aware of the prevalence of high risk for bleeding patients in our practice. And when it happens, the death rates, mortality is extremely high, and sometimes even higher than a thrombotic event. So for the past few years, we've been struggling and striving to come up with the best solution to treat these patients. We stopped clopidogrel, we stopped aspirin, we stopped both, prolonged, short, but to have a device that can be less thrombogenic and not to be dependent on multiple drugs, this would be fascinating to me. And again, this is what I have to present today, DS, the Design DS Plus, BRS Plus, which is really the combination of a very thin metallic strut with 3 different drugs being delivered to the vessel wall through a bioabsorbable polymer: sirolimus, agatroban, and rivaroxaban. Needless to say that sirolimus is a very potent anti-proliferative drug that inhibits neointima formation. And now we combine 2 anticoagulants, direct factor XA, 10A inhibitor with rivaroxaban, and a direct factor 2A inhibitor, which is the argatroban. So with the combination of both, you're going to have a more potent inhibition of thrombus formation on site. So this is the rationale behind this novel triple therapy device. So this is the design of the Design BDS Plus randomized trial. So we included 100 patients, 200 patients, 100 patients for the active group, and 100 patients for the control group. As you can see, this is a very unique study design because we collect at the end point at the hospital, during the hospital stay. because we want to see what happens in the more perhaps thrombotic milieu if we could have less TLR as compared to the control arm. It's a proof of concept that this was not powered to show reduction in events, and we have a subset of patients with angiographic analysis at 6 months to measure late loss. But we keep following these patients up to 3 years, as I'm going to present today. There was a small subgroup of patients that we did PK study to measure the concentration of these 3 drugs in the circulatory and the systemically as mandatory for many regulatory agencies. Here are the demographics, multiple risk factors, as you can see. Diabetes was more frequent in the active group with the design BDS Plus. As you can see, 20% versus 15% in the control arm. Also, I would like to highlight the fact that we had at least 1/3 of these patients with acute coronary syndrome. Not ST elevation MI, but acute coronary syndrome that could be a more thrombogenic situation. Also, you can appreciate that most of these patients were having aspirin and the P2Y12 inhibitor in 70% in both arms. These are the primary endpoint that was already presented and published at CCI by my good friend Stéphane Veillet. You see that there was absolutely no events, no death, no TVMR, and no TLR in the active group, as opposed to 5% in the control arm. So we might see really some biological effect on site in this first few days after this stent deployment. But this is perhaps the slide to memorize out of this presentation. This is the 3-year follow-up. As you can clearly see, there is a p-value in advantage of the purple line, which is the BDS Plus, the triple therapy, versus the control arm in green. So 12% versus 3%. Again, despite this is a 200-patient study, to me shows a signal that this device can be less thrombogenic with 0 stent thrombosis, definite or probable, versus a couple of events in the control arm. Also important is to share very briefly the PK study that didn't show any therapeutic level for the 3 drugs, sirolimus, argatroban, and rivaroxaban. That, I think it's fair to conclude that the 3-year results from Design BDS Plus randomized trial demonstrated the sustained lower adverse events with this more site-specific antithrombotic drug therapy. As I mentioned, no stent thrombosis with significantly lower target lesion failure as compared to the control arm. The subset that we analyze drug concentration systemically showed that there was not therapeutic effect, but also in the circulatory, systemically, but in this subgroup there was no TLF. And this 3-year outcome really demonstrated promising safety and efficacy of the site-specific antithrombotic therapy on the Design BDS Plus platform as a potential solution for patients that will undergo PCI with high risk for bleeding. Thank you so much.
Thank you, Alexander, for sharing these nice results and truly an innovative stent design. Let me ask Valeria, who is also an expert on abbreviated DPT. What is your impression of this?
Thank you, and congrats, Dr. Abizaid. I think these results are striking. I think we all agree with the fact that at a certain point we thought that with the new DES we reached the plateau, that there were no new ideas coming up. We really reached what we could get from these devices, but it's fascinating to see there are new ideas coming up and also have been applied to technologies, and these are promising results. Of course, we need to acknowledge the number of events in this trial. This is a proof of concept, limited to show some clinical outcomes, but these first results are really impressive. The idea of tackling this coagulation cascade at different level is particularly triggering in patients who we know are at a high bleeding risk,
these are the subgroup of patients where I think this device could have a very an impact, an important impact. And my idea is, if we are tackling this coagulation cascade at the local level, do you think there might be room, for example, for dropping aspirin in this patient right after the procedure, despite the fact that, you know, the data we have up to now are not very convincing? There have been some safety issue with trials trying to drop the aspirin right after the PCI.
Yeah, that is really, thank you, Valeria, for your comments. I think this is really fascinating, the concept to be able to, in patients with super high risk for bleeding, to be able to eliminate perhaps not only aspirin, but both. We have just to remember that a patient, for instance, with acute MI, ST elevation MI, are a very inflamed patient. The thrombotic phenomenon sometimes just doesn't help specifically in that site. So I think that the whole rationale why we keep insisting on dual therapy is just because the patient can develop another, you know, the neighbor vessel, some phenomenon. Yeah. So being said that, I really believe that for the lesion specific that we are dealing with, and if the patient has, for instance, an oncological patient has cancer or any other situation that you might be able to eliminate both drugs, that to me would be the holy grail for this technology. But again, we need to test. This specific was study design didn't prove that, because we could allow the physicians to prescribe the antiplatelet therapy for all the patients as they wished. But I think this is a great hypothesis generating for a very short or eliminating one or the two drugs.
Alex, don't you think that the thrombosis event, thrombotic event in the control arm were a little bit high? Higher than what we normally expect in this type of lesions.
Yeah, we had I think 2 patients in the control arm, and there was 2 deaths. And you know what? I think in 100 patients, Antonio, if you see 2 or 3 cases, I think that it could be by chance, of course, but it didn't alarm me too much.
Yeah, no, but the same consideration can be applied to the other group.
Yeah, exactly, exactly. But this is again a hypothesis generating study.
And the other issue is why, considering that stent thrombosis is mainly a platelet mediated event, at least in the early time, why did the company selected an anticoagulant regimen and more than an antiplatelet regimen?
I think it would be a little bit harder to put aspirin on the top of the stent, first of all. And I think that all the preclinical work that they did using this true in the next 6 months is even more attractive. It's not only for the first few hours, but these 2 anticoagulants will have a half-life and be able to control the release over this polymeric material over time, even longer than sirolimus.
Yeah, I think, Alexa, this is a wonderful idea. And we're also doing a study in which we're coating with a drug, tirofiban. And just to see what happens, we call it a dual drug-eluting stent. And I think this kind of a stent will have a very good niche in those patients who have to go for any surgery, where you have to necessarily stop the antiplatelets, or even if a patient is a very high bleeding risk case and bleeds. I think this is the kind of, will have a very important niche, and I think we need to carry on this study with more complex patients. Yeah, thank you.
In line of that, do you also think that apart from high bleeding risk patients and patients that cannot have antiplatelet therapy because of upcoming surgery, etc., that maybe also thrombotic lesions, STEMI patients might be a good indication?
Both, yes, precisely. I think that if you have a combination of a high risk for bleeding patient that comes to you with acute coronary syndromes and ST elevation MI that was not tested in this study, I think will be probably the best indication. But again, I come back to you with another question. If this is good, safe, and it's very efficient in this kind of lesions, why not using all of the lesions, right?
That's true.
I have maybe one last comment. Alex, any concern about delayed intimal coverage? Do you have any OCT intravascular imaging data?
Valeria, I think this is a fantastic question. If you stop and think of the mechanism of action of these drugs, I think what really delays endothelialization is antiproliferative drugs such as sirolimus. I don't anticipate that an anticoagulation drug will have, effect on delay endothelium. But for sure, an OCT sub-analysis will be fantastic. There were few patients in this study. There was a sub-study of angiography. But I think as we move more aggressively deeply into this research, I think we're going to have to provide this kind of imaging data as well.
I think for the purpose of time, we'll have to move to the next presenter. This is a great study paper. So we're going to hear about the recurrent revascularization at 10 years after treatment with biodegradable versus permanent polymers, and Dr. Hug is with us.
Yes, thank you very much for the introduction. It's a pleasure being able to talk to you this afternoon. I'm presenting to you a post-hoc recurrent event analysis of the ESA-Test 4 trial. In this post-hoc recurrent event analysis, we aimed to analyze the total revascularization burden at 10 years after treatment with a biodegradable versus 2 permanent polymer drug-eluting stents. The original ESA-Test 4 trial was a trial comparing an early biodegradable drug-eluting stent with 2 permanent polymer drug-eluting stents. And on the left-hand side, you can see the 10-year results for TLR, which showed numerically higher rates of TLR in patients treated with the early generation permanent polymer drug-eluting stent compared to the other 2 stents. However, the total revascularization burden is not always completely acknowledged in time to first analysis as this Kaplan-Meier analysis, and that's why we aimed to perform the total event analysis. So let me show you the study flow of this analysis. On the left, you can see that the patients were randomized in a 2-to-1-to-1 fashion. 1,299 patients were randomized to the new generation biodegradable polymer sirolimus eluting stent, which was the Yukon choice. 642 patients were each randomized to the early generation permanent polymer sirolimus eluting stent, the Cypher, or new generation permanent polymer everolimus eluting stent, Science. And in this now total recurrent event analysis, we analyzed first TLR, but also a subsequent repeat TLR to analyze the total event burden. So the endpoint was this total revascularization burden in terms of repeat TLR, and that was defined as any repeat PCI of the index lesion, so excluding bypasses. Baseline characteristics were well balanced. We had some exclusions. We have age, which shows a little bit higher age in patients with no repeat TLR. Also, patients with no repeat TLR had less often stable angina, more often stable angina, and less often 3A vessel disease. Bayesian lesion characteristics showed some differences. Patients with no repeat TLR had less complex lesion complexity, and also other specifics were a little bit different. So let me now turn to the results of this analysis. On the left, you can see that performing the recurrent event analysis, there was a 57% increase in observed lesions compared to the time to first analysis, which showed only 517 events, and now we have 717 events observed. Importantly, this was across all randomized treatment arms. Hazard ratio analysis showed an outcome in favor of the biodegradable polymer eluting stent with a hazard ratio of 0.77 and a p-value of 0.028, comparing the biodegradable sirolimus eluting stent with the permanent polymer everolimus eluting stent, there was no statistical significant difference. This slide shows the evolution of TLR, where you can see that 442 lesions had a first TLR, and 33% of these lesions, which is 146, required a second TLR. Overall, 2 lesions required 8 TLR, which was the maximum TLR count. This is the same slide as on the previous slide. And what we see here is the total number of repeat TLRs according to treatment arm. And we show a similar development across all number of repeat TLRs. The treatment strategies were according to operators and were well balanced between the treatment groups. We can see that in the first 2 TLRs, there was a tendency to more stent implantations. And after the second TLR, there were more drug-coated balloons used. So to conclude this presentation, firstly, there was a 57% increase in observed repeat TLR events when using this recurrent event analysis compared to the conventional time to first event analysis. And second, the new generation biodegradable sirolimus eluting stent is able to reduce the need of repeat TLR compared to early generation permanent polymer sirolimus eluting stents over 10 years. So what I'd like you to take away is firstly that this recurrent event analysis enabled capturing an additional treatment effect that was not able to capture in the time to first event analysis, and that for the first time we can show that a new generation biodegradable drug-eluting stent is able to reduce the need of repeat TLR compared to an early generation permanent sirolimus eluting stent. So finally, I'd like to acknowledge all my colleagues and my mentors for participating in the study, and thank you for your attention.
So, Dr. Call, if you can comment on this, please.
Well, I must congratulate Dr. Kastner for getting this very new concept. Most of us don't believe
Thank you.
Isn't it? And it makes sense that the first TLR which happens is not the last TLR. The stent is going to stay there for years to come. And we need to judge the performance of a stent over a long period of time, as you have done in 10 years. 40 to 50% have events. Now, the other information which I get it that the biodegradable sirolimus eluting stent, the Yukon,
Yes.
and this fixed polymer stent, the Zymes, up to 10 years, they're similar.
Yes.
Isn't it?
Yes.
So the theoretical advantage of biodegradable polymer is not seen. It still eludes us.
Yes.
So that is the reason I think thinner struts came in. And the thinner strut with a biodegradable polymer possibly is working.
I think it's very important to address this. This is a bias which you have to address because we're not only comparing the polymer.
Yeah, because the strut thickness comes in there. And also, I think you have been a little unfair to the first generation stents. The events, although numerically higher, are not statistically significant. In Cypher, which you showed in the first slide,
Yes.
they're higher. So I would also like to see a difference between Cypher and biodegradable polymer stent. You have not compared that. Or Cypher versus Zymes. In 10 years.
So we have not compared the Cypher with the Zymes, yes.
That also will be interesting because we have short-term, these things only, not long-term.
Yeah.
The other thing is that the baseline variables, which you said are similar, are really not so similar because 5 out of 9 points, which you said, have, differences. Some of them very close to significance. Now, like patients with recurrent TLR are older. Patients with no recurrent TLR are older, and they have more diabetes and less symptoms. So,
yes.
Does it make any significance? And also, which statistical method has been used, which counts the events? Is it the Anderson-Gill method, or it is,
Yeah, we use the Anderson-Gill method too.
Yeah. So finally, I would like to congratulate you and your team at, Munich to go for this 10-year follow-up. Very few institutions, I think, can do this 10-year follow-up and come out with numbers.
That's what makes it unique. Yeah.
Thank you.
But yes, congratulations. 10 years is a lot of time, and
Thank
this
you.
is valuable data. Not just because it's a long time, but a lot changes in 10 years. Medication, potent antiplatelets, for example, lipid-lowering therapies have changed in the last 10 years. Diabetes medications have changed. And I think that certainly impacts event rates. It's not just the stents that we use, but this information is still valuable. Thank you very much. So maybe we move to the next.
Well, I have one question. Restenosis is not a benign entity. There's studies showing that treating instant restenosis is also causing to increase of target vessel MI and even death. So you only looked at TLR. Did you also consider thinking about looking at other endpoints as well?
Yes, we did consider that. However, TLR is felt the most natural because for this kind of analysis, you really need a close follow-up, and if you miss out on any events, then I think the analysis is not proper to perform. Of course, you could do a target vessel, but that again doesn't only account for the stent. So for the whole vessel, there are other lesions too. So.
I'd love to see the target vessel failure rates in these kind of studies. Thank you very much.
Thank you.
We continue with the last presenter. Futushu Yamamaka will talk about percutaneous coronary treatment with Bioadaptor versus stent, the 4 years outcomes of the Bioadaptor RCT.
Okay, thank you, Chairperson. I'm Futoshi Yamanaka from Shonan Kamakura Hospital, Japan. I'm great honor to give a presentation here. Today, I'd like to talk about a 4-year clinical outcome in Bioadaptor randomized control trial. I do not have any conflict of interest. This is a randomized control trial, 34 global trial sites in Japan, Europe, New Zealand. So we are sincerely grateful for all collaborators. Looking at the background, so this is a rate of target lesion failure. So even in contemporary second death, so target lesion failure keep going up event rate after 1 year. Blue line is drug-coating balloon groups. As you can see, drug-coating balloon is also keep going in terms of cumulative incidence of target lesion failure. To date, so these are remaining clinical issue. This Bioadaptor stent is well designed to adapt to vessel physiology. First 6 months after implantation, Bioadaptor supports the vessel wall potentially contribute to future reduction in coronary event. So this is our hypothesis. So 2 randomized control trials already published, JAK intervention and the Lancet. As you can see in the both trial, so after 1 year, after 6 months, so event rate appear to be plateau like this. These future could be seen in both randomized control trial. This is a Bioadaptor randomized control trial flowchart. So this trial included 445 patients were enrolled. So 1-to-1 randomized trial, randomly assigned to one-to-one bioadapter group and Resolute Onyx groups. A primary endpoint was 1-year clinical follow-up in terms of target lesion failure. So today, we'd like to talk about 4-year clinical outcome bioadapter randomized controlled trial. This is a baseline characteristics. Left side is patient characteristics, patient background. Right side is lesion characteristics. As you can see, so LED lesion is approximately 50%, and the bifurcation lesion around 24%. So more complex lesion is included in this clinical trial. So any compounder is well balanced between two groups. Looking at the 4-year clinical outcome, as you can see, significant differences between two groups. Notably, 1-year follow-up, so event rate is quite low in bioadapter groups. 4-year follow-ups, bioadapter groups are 2.8%. Conventional DS group is at 7.8%. Significant difference, as you can see. This is a component of target lesion failure. So as you can see, so all component drives the reduction in target lesion failure. Notably, cardiovascular event is significantly lower in bioadapter groups. Looking at landmark analysis, as you can see, after 6 months, significant lower event in bioadapter groups. As you can see, the difference keep going to significant p-values. This slide shows target lesion failure outcome in LAD lesion. This is a subgroup analysis in LAD lesion. Even in LAD lesions, as you can see, significant difference between two groups. This slide shows the incidence in target to vessel failure. As you can see, significant difference between two groups. So clinical event is more significant reduction in target to vessel failure in bioadapter groups. This is our conclusion. Bioadapter randomized control trial demonstrated significant lower target lesion failure rate. Also showed a significant reduction in cardiac death and substantial clinical benefit in LAD lesions. Thank you so much for your attention.
Thank you for showing those important long-term outcomes with the Bioadapter and the Bioadapter randomized control trial. Antonio, you're a user of Bioadapter. I think, what is your comments on this trial?
But, you know, my comment is also a question for the presenter. And then I give you my comment. In Japan, is this device available for clinical use or only inside trials?
Thank you so much for your question. So your question is, so Bioadapter is available in Japan or so?
Yeah, is available for general use or only for clinical trials?
Yes, and now so not available in Japan because in the near future, so it will be available maybe this year.
Okay, so my consideration is, you know, with these results, I already said this 1 year ago. Why this device is not more routinely used? Because, you know, honestly, these results are quite impressive. if I had a stent tomorrow, I would like to have this device, and makes sense. So it's, I know the price is not competitive, but this procedure is not like going to the dentist. For some people, are relevant procedures.
No, sorry, but I must agree with what you say, because if you look at the target lesion failure and target vessel failure, they are 2.8% and 3.3%. This is at 4 years. This is extremely low. So honestly, I don't remember if I've seen something similar to that. So how can you explain? Because I also saw that you have 20% calcification rate. Heavy calcification, which is not extremely high, but is in the range of the Renovate complex trial, which is quite complex. So how you explain that is doing so good in simple but not that simple lesion? Is only because the vessel reacquired the vasomotion, let's say?
Thank you so much for nice question, nice comments. It have been reported that using Bioadaptor is associated with long-term vessel function, such as increasing blood flow and good vessel function result in a nice vessel remodeling. That feature might contribute to lower event in target vessel. So I think much more data we have to need to further analysis.
We published, I think this year, in American Journal of Cardiology, first author is Pier Pasquale Leone. In complex lesion, I think we are 54. We did rotablation, lithotripsy, so there are real many CTOs with routine angiographic follow-up, and we had only 4 or 5 revascularization out of 54 with routine angiography, and we know that routine angiographic follow-up triggers reintervention. So it goes along with your data.
Well, my comment also is in the same direction. We have 3 years, 4 years data showing mortality benefit, not only the recurrence benefit. And yet we're not seeing it, being used frequently, commonly. And, I don't think it's US FDA approved as yet. It's not.
Well, thank you, everyone. This has been a lot of fantastic data. I think we all recognize that we've reached a plateau with drug-eluting stents in terms of event rates, and it's really refreshing to see new technologies trying to push the envelope. So what we did see today is Bioadaptor sub-analysis on intracoronary and physiology evaluation. We saw long-term outcomes, 4 years for this technology, which is very promising. We saw something very new from site-specific antithrombotic. We're really excited to see where this will head, Dr. Abizaid and his team. And of course, we also saw the thinner strut fire absorb, very promising results, and we're hoping to see a little bit more come out of that technology as well. So thanks, everybody, and hope to see you in other sessions.
Thank you.
Thank you. Good seeing you.